All right, let's dive right in. In this explainer, we're going to break down a really complex and serious lung condition called Idiopathic Pulmonary Fibrosis, or IPF for short. It's all about progressive scarring of the lungs. And if you're in the medical field, understanding its key features is absolutely crucial. So, let's get started.
And before we jump in, I want to give a huge shout out to Dr. Mohammed El Nagi Mohammed. All the information we're about to cover is based on his incredible work. We're basically distilling his key insights to make this topic as clear and, honestly, as memorable as possible, especially for your studies or your clinical practice.
Okay, so here's our game plan. First, we'll nail down exactly what IPF is. Then we'll paint a picture of the typical patient. After that, we'll get into the signs and symptoms, how it's diagnosed, what treatments are available, and finally, we'll look at the long-term prognosis.
So first things first, what exactly are we talking about when we say idiopathic pulmonary fibrosis? Let's break down the name because it tells us a lot.
At its very core, IPF is a chronic disease where the lung's interstitium, that's the super delicate tissue framework around the air sacs, gets progressively scarred. You could just imagine that as this scar tissue, or fibrosis, builds up, the lungs get stiff and hard. And that, of course, makes it harder and harder to breathe. The key word you've got to remember here is progressive. It doesn't get better.
Now, let's zoom in on that first word, idiopathic. This is a huge deal. See, we know some things can cause lung scarring, right? Things like asbestos exposure, certain medications, or autoimmune diseases. That's what we call secondary fibrosis. But IPF is different. The I in IPF for idiopathic means the cause is unknown. We simply don't know what kicks it off.
So, if we don't know the cause, can we at least figure out who it tends to affect? Who's the typical patient? Well, it turns out the data gives us a surprisingly clear picture.
First off, think age. This isn't a disease you typically see in young people. The diagnosis almost always happens in folks between the ages of 50 and 70. It's a condition that shows up later in life.
And it's not just about age. There's also a really clear gender split. IPF is twice as common in men as it is in women. So when you're trying to form a mental picture of a classic IPF patient, you should be thinking of an older male.
Okay, so we know who gets it. Now, what does it actually look and feel like? What does the patient complain about? And what are you going to find on examination? Let's get into the classic signs and symptoms.
You really need to lock in these 4 key features. Number 1, a progressive shortness of breath, especially with activity. Number 2, and this is a big one for exams, are the sounds you hear in the lungs, bibasal, fine, and inspiratory crepitations. You know the sound when you pull apart Velcro? That's almost exactly what it sounds like. It's the sound of stiff little airways popping open. Third is a nagging, dry cough. And finally, you might see clubbing, which is a change in the shape of the fingers and nails.
So, you've got the symptoms, you've heard those crackles on the exam, but how do you actually confirm it's IPF? That's where the diagnostic pathway comes in. You can't just guess. The journey to a diagnosis is basically a 3-step process. You start with spirometry to check the lung mechanics. Then you do a gas exchange test to see how well the lungs are actually working. And finally, the big one, a high-resolution CT scan to get a direct look at the lung tissue itself.
Okay, spirometry. This is a huge clue, so you've got to understand this part. IPF gives you what's called a restrictive picture. Think about it. The lungs are scarred and stiff, so they can't expand fully. That means the total amount of air you can breathe out, the FVC, is going to be lower. But the airways aren't blocked, so you can still force the air out quickly. That makes the FEV1-FVC ratio normal or even a little high. That restrictive pattern is a classic clue.
Next up, that gas exchange test. If spirometry tells you about the mechanics, this tells you about the main job of the lungs. And in IPF, the transfer factor, or TLCO, is reduced. That scar tissue is basically building a thick wall between the air in your lungs and your bloodstream, making it way less efficient at getting oxygen across.
But the gold standard, the definitive test you absolutely need, that's the high-resolution CT scan. This gives us a beautiful, detailed picture. And you're looking for specific patterns. Early on, you might see this hazy, ground glass look. But as the disease gets worse, you see something called honeycombing, which is the absolute hallmark of advanced fibrosis. It literally looks like a honeycomb where healthy lung tissue used to be.
Now, what about blood tests? This is where things can get a little tricky. You'll see that about a third of patients might have a positive ANA, and 10% a positive rheumatoid factor. But here's the critical part. This does not automatically mean they have an autoimmune disease. In IPF, these markers can just show up on their own, as part of the disease itself. It's a potential red herring.
Okay, so the diagnosis is confirmed. Now you're facing the really tough question. What can we actually do for these patients? Let's talk about management.
The truth is, our options are pretty limited. You can group them into two main camps. First, there's supportive care, like pulmonary rehab and oxygen, which is all about managing symptoms and improving quality of life. Then you have treatments that try to slow the disease down, like the antifibrotic drug pirfenidone. And slow is the key word there. It doesn't stop it or reverse the damage. Ultimately, for patients who are eligible, the only curative option on the table is a full lung transplant.
And all of this brings us to our final section. And honestly, it's a sobering one. We have to talk about the prognosis for someone diagnosed with IPF.
Look, there's just no easy way to put this. The prognosis is poor. This single number really tells the whole story. The average life expectancy after diagnosis is just 3 to 4 years. It's a direct result of that relentless progressive scarring. And it just hammers home how urgently we need better treatments and more research.
So that leaves us with this final question. With such a challenging outlook and so few tools in our toolbox, where do we go from here? What does the future of IPF treatment even look like? The answer really has to lie in research, in finding better antifibrotic drugs, exploring regenerative medicine, and, most importantly, finally figuring out what causes this devastating disease in the first place.